Thank you, everybody. This is the first of hopefully many more webinars. Tonight, we are going to be talking about the condition of obstructive sleep apnea, which is a subject very near and dear to my heart. I have been in sleep medicine for over 30 years. I sort of jumped in at the very beginning when CPAP was invented in the early 80s. And I have been treating patients with a variety of sleep problems, most commonly sleep apnea, but other sleep conditions as well. I'm a physician here in private practice in Edmond, and I specialize in sleep medicine. Tonight's topic is obstructive sleep apnea, and I'm sort of the lead guy, and I'm going to be talking about I'm going to set it up for the other two physicians who are coming on. I'm going to be talking about symptoms and treatment options for obstructive sleep apnea. Next slide, please, Hannah. Okay, I'd like to first start with a definition of terms. I want to make sure we're all on the same page. The term apnea comes from the Greek word meaning to be without breath. An obstructive apnea is defined as an absence of breathing or airflow for a minimum of 10 seconds. And with an obstructive apnea, there is a continued attempt to breathe. What basically has happened is the upper airway is either completely or partially obstructed, and efforts to continue to breathe with the chest and the abdominal muscles are present. This is in contrast to something called central apnea, in which there is a complete absence of breathing. That's usually a problem with the central nervous system and the brain. Suffice it to say, for tonight's discussion, we're going to be talking about obstructive apnea, which is basically 90% of sleep disordered breathing. Next slide, please. In order to understand the disease, you first need to understand how common it is. The term prevalence refers to the percentage of patients in a given population who have the condition. As you can see from this slide, obstructive sleep apnea is incredibly common. It is present in 40% of postmenopausal women. In fact, the number is probably higher now. African Americans, 25%. Patients of Asian descent, 13%. And one of my favorites is NFL football players, anywhere from 15 to 19%. And the next slide shows a very famous NFL football player that many of you are familiar with, Reggie White, who passed away on December 26th in 2004. Reggie had several medical conditions, but probably the most significant of which was untreated sleep apnea. And of course, he unfortunately passed away during sleep. Next slide, please. Probably the largest study of obstructive sleep apnea and its prevalence and consequences is something that is referred to as the Wisconsin Sleep Cohort Study. This was a study that was started and is currently ongoing in the state of Wisconsin. It started in about 1988. It enrolled several thousand patients, and it has followed them over all of these years. And from the prevalence data, obstructive sleep apnea was noted in children between the ages of 2 and 8 years, approximately 2 to 4%, which is quite significant. In adults with mild apnea, as defined by fewer than five episodes per hour, 24% of the males and 10% of the females showed evidence of mild apnea. With moderate apnea, the number was 15% and 9% respectively. And for adults with severe apnea, in men, anywhere from 7 to 14%, and in women, 3 to 7%. That is quite significant given the fact that these were relatively normal people living independently in a community in Wisconsin. Next slide, please. So when you break it down, how do you figure this out? Well, it is well known that approximately 40% of the general adult population snore on a regular basis. It is also well known that men snore far more frequently than do women. Obesity doubles the risk for sleep apnea in patients who have habitual snoring. And it is also known that approximately 60% of people who have habitual snoring have obstructive sleep apnea. When you put it all together, that comes out with an astounding number of approximately 25% of the general adult population may have and be at risk for obstructive sleep apnea. So this is certainly a condition that is extremely common and greatly underdiagnosed. Next slide, please. Now, what does this mean? What does obstructive sleep apnea actually mean? Well, what it means is the upper airway, called the pharynx, and I know Dr. Hansen has slides on this. The pharynx is that part of the throat from basically the end of the nasal passageway down to the base of the tongue. The pharynx is a muscular tube that is used every day. It has to do several different things. The pharynx is involved with the act of swallowing and eating. It's also involved with breathing and, of course, speech, phonation. The pharynx responds to phonation. So you've got a relatively small tube that has to fulfill 3 different functions. So it's incredibly complicated. Most of the patients who have obstructive sleep apnea have areas of obstruction with the pharynx. And what that little arrow is showing, that the base of the tongue collapses against the posterior pharyngeal wall. In other words, when people are sleeping, the muscles that tend to keep the airway open relax, the airway becomes unstable, and it tends to collapse. And that is basically the mechanism by which obstructive apnea occurs. Next slide. Now, there are a number of contributing factors that make obstructive apnea worse. This slide lists the major contributing factors: blockage of the nose, enlargement of tonsils and adenoids, anatomic conditions involving the jaw, the mandible, the tongue, as described above. Obesity is probably the single most important risk factor for sleep apnea. It is not the only risk factor, but it is probably the major risk factor. The size of the neck, the circumference of the neck is very important, as is the BMI. In general, the larger the BMI, the more likely somebody is to have sleep apnea. Males are affected more than women, and in premenopausal women, their female hormones seem to be protective of the upper airway. In postmenopausal women, you saw from the first slide, they lose that protection, and therefore postmenopausal females are almost as likely to have sleep apnea as are males of the similar age. There are other medical conditions that are associated with risk for sleep apnea: thyroid conditions, glandular conditions. Certainly drugs are very significant in precipitating sleep apnea. In fact, many cases of sleep apnea are diagnosed in patients who undergo anesthetics for various procedures. On more than one occasion, there have been arrests in the recovery room following colonoscopies and surgery where anesthetic agents were used. Alcohol worsens sleep apnea by relaxing the upper airway muscles. And of course, genetics is a major factor. Next slide. The clinical signs and symptoms of apnea are well known. Everybody knows very loud snoring is present in almost 100% of patients. Restless sleep is noted. Conditions of choking, witnessed apnea, shortness of breath upon awakening is present. What is probably not well known is 70% of patients with sleep apnea complain of heartburn and GE reflux. And often it is very difficult to treat those conditions until the apnea is treated. Waking up at night to urinate, which a lot of older men attribute to their prostate, is extremely common in sleep apnea and goes away with treatment. Next slide, please. I want to get all of this in my 15 minutes. Daytime consequences of sleep apnea are very important. The primary one that brings most patients to the physician is complaints of daytime sleepiness. Excessive sleepiness, fatigue, inability to stay awake without taking naps is probably the most common symptom. That's due to disrupted sleep at night. However, there are other subtle problems which may be difficult to account for and may be underappreciated. Problems with memory, concentration, personality changes, worsening of mood disorders, and depression may all be seen in sleep apnea. In fact, there's a condition of pseudo-dementia in which patients actually present as if they were developing Alzheimer's disease. That is one of the most reversible and treatable complications of sleep apnea, and anybody who is being worked up for dementia should probably undergo a sleep evaluation. Sexual dysfunction in men with impotence, extremely common. Low testosterone levels are also common. Next slide, please. So why is it important to diagnose and treat this condition? Well, the next few slides will go into it, but basically, patients who have sleep apnea have a tremendously increased risk for cardiovascular morbidity and mortality. In other words, they die. Patients who are compliant with treatment for sleep apnea have very little risk of having excess mortality as long as they are compliant with treatment. Next slide, please. This slide summarizes the major medical consequences of untreated sleep apnea. Number one on the list, hypertension, high blood pressure. Patients who have high blood pressure may have a prevalence of 50 to 70% obstructive sleep apnea. Patients who have resistant, that is difficult to control blood pressure, have an incredibly high risk of having sleep apnea. Up to 90% of patients who require 2 or more blood pressure medications to control their blood pressure may have sleep apnea and should be evaluated. The risk for stroke is greatly increased in patients who have sleep apnea. In fact, 70% of patients who present to a stroke unit are ultimately diagnosed with having sleep apnea. In addition, risk for heart attack, cardiac arrhythmias, particularly atrial fibrillation, worsening of diabetes, all of these things that you see on the graph are directly associated with untreated sleep apnea. Next slide, please. So what are the treatment options? I'm just going to mention these briefly because I've got 2 other brilliant clinicians who will go through them in detail. Probably the most common and probably the best known treatment is nasal positive airway pressure, what we call CPAP, or bilevel pressure. That is pressure that is directly applied to the upper airway. As you see from the slide, it requires the application of a mask of some kind to keep air pressure in the upper airway. It is probably the safest, quickest, and least invasive form of treatment if somebody can tolerate it. And the way it works is it blows air into the upper airway, splints it open, and prevents the pharynx from collapsing. Next slide. Another excellent form of treating sleep apnea, mild to moderate sleep apnea in patients who either want an alternative to CPAP or cannot tolerate CPAP, is the use of an oral appliance, a mandibular advancement splint. Dr. Winters is going to talk about this in great detail, but basically as you see from the graphic, what the mandibular splint does is it moves the lower jaw down and forward, opening up the posterior tongue space to allow for adequate breathing. Very effective therapy and very well tolerated. Next slide, please. Just a few more moments. Dr. Hansen is going to talk about a very exciting technique of actually anatomically expanding the palate, the upper part of the jaw, to enlarge the oral opening. This is particularly important in children who have sleep disordered breathing. Next slide, and this is second to the last slide. Surgical options, we don't use them much anymore. A number of years ago, about 15, 20 years ago, we were doing lots of surgical procedures on the palate to try and open up the throat. Most of these did not work. They were incredibly painful. Their overall success rate was poor. So we really don't use surgical techniques very much unless somebody is a total CPAP failure and has a particularly beneficial anatomy, then we would consider it. And then finally, the last slide, there are other behavioral factors that come into play. Weight loss, of course, because sleep apnea is strongly correlated with obesity. So weight loss is very beneficial. In fact, as you see from the slide, 10% weight loss buys you about a 25 or 26% improvement in your sleep apnea. So we always recommend weight loss. And with that, I'm going to turn it over to other colleagues. Thank you very much.
Awesome. Thank you so much, Dr. Cole. For those of you that have joined us maybe during Dr. Cole's presentation, we have Dr. Cole here, Dr. Hansen, and Dr. Winters. Next, we're going to turn it over to Dr. Hansen. I just want to remind anybody that's watching, if you do have questions, there's a chat box on Zoom, and then comment box for Facebook. The doctors will stay on for a few minutes after their presentations to answer any questions that you guys might have during the meeting. And Dr. Hansen, it's over to you now.
Okay. Thank you, Hannah. Thank you, Dr. Cole. That was very informative. I just kind of wanted to pick up, where he left off and focus on one particular aspect of this problem, and that is the structural side of the problem. We've come to understand that obstructive sleep apnea and other sleep disorder breathing problems have an underlying structural cause or component, and problems with the bony development of our jaws can lead to these particular types of breathing problems, because these bones that we're talking about make up the scaffolding of our airway. To better understand this structural problem, it's helpful to understand how these bones are supposed to develop. Skeletal growth of the skull, of the head, centers around the brain for the first 2 years of life. And then after that, the lower face and jaws slowly begin to catch up. As you can see from this slide here, the jaws, which are the lower half of the skull or the lower 2/3 of the face, grow in a downward, forward, and wider way as they complete their development. This might be easiest seen from a profile view of total cranial growth by year. Each ring here represents a year of cranial growth. We'll start with age 2, after most of the upper cranium has developed. We'll see that each consecutive year after that, the majority of the growth that happens is in the lower 2/3 of the face. And we can see that it's happening in a downward and forward projection as we age. most of us are finished growing skeletally by 17, but we'll see that most of that growth happens earlier in life than that. But the take-home message is that normal craniofacial growth is wider, is forward, and it's downward. So I want to focus on one of those bones in particular, the maxilla, also known as the upper jawbone. It is the critical piece in this structural puzzle. It makes up, as you can see here highlighted in orange, it makes up the majority of the midface, including large portions of the nose, lower portion of the orbits of the eyes, the sinuses, and of course the upper jawbone that holds the teeth. The maxilla is an interesting bone. It's made of a functional bone that is very susceptible to external forces, particularly the muscles that surround it. If there's an imbalance or improper function of these muscles, it has an inhibiting effect on the growth of the maxilla. And when this bone is not big enough, one of the first signs that jumps out to us as dentists is crowded or crooked teeth, something we call malocclusion. And one of the most important muscles in this system is the tongue. And the tongue, of course, plays a major role in the development of the upper jaw. When the tongue is functioning correctly, it rests in the roof of the mouth. When we swallow properly, the tongue pushes against the upper dental arch and helps the upper jaw grow properly in a wider outward and forward direction. When the tongue is resting properly on the roof of the mouth, it counterbalances the inward forces from the cheek and lip muscles. And if the tongue is not functioning properly, these lip and cheek muscles can overpower the natural growth of the maxilla, that upper jawbone, causing it to not reach its full size potential, or even in some cases constricting it and shrinking it. So we know that having a strong, well-developed tongue is important in making sure that our arches develop correctly. An important component to proper tongue function, interestingly, is nasal breathing. When you breathe through your nose, the air is warmed, filtered, humidified, and spun like in a centrifuge. And this allows your body to pick up richer, cleaner, more abundant oxygen. And when you breathe through your mouth, this doesn't happen. Instead, unfiltered, dry air is continually entering that area, hitting the tonsils, often resulting in inflamed and swollen tonsils, which further impact your ability to breathe. In addition, nitric oxide is produced in the paranasal sinuses of the nose. Nitric oxide is a vasodilator, it makes the blood vessels open up. And that further helps our body absorb oxygen well. And when you breathe through your mouth, the oxygen is not mixed with this nitric oxide, so your body does not absorb oxygen as efficiently. So nasal breathing is very important for our bodies and for our health. But another important thing to remember is that the floor of the nose is also the roof of the mouth. And any underdevelopment or malformation in that upper jaw and that maxilla has an effect on the nasal passages and vice versa. When we breathe through our mouth, it is impossible for the tongue to maintain contact with the palate, and therefore the lip and cheek muscles constrict the development of that upper jaw. So if we look at this dysfunction of the muscle system, it leads to an underdeveloped, smaller than ideal upper jaw. Interestingly, the lower jaw does not as easily succumb to these pressures, in part because it is made of a different type of bone, one that's much more dense. It's a different cell line of bone. But it also, the other part of that equation is that the lower jaw is the only moving part. And as such, it has the ability to position itself back or move out of the way of some of those constricting forces. And one way to illustrate this a little bit with some kind of household items, sometimes we'll use measuring cups to illustrate this, because everybody's familiar with measuring cups. Clearly in this example, the upper measuring cup, the white measuring cup, is smaller than the red cup. If we think of these cups as the upper and lower jaws, we can see that like I said, the upper is clearly smaller than the lower. But if we wanted to use the edges of those cups to chew food with, the most stable position is to position that lower one back just a little bit to allow as much surface area of the edges to line up as possible. And even in that example, you can still clearly see that the lower jaw is bigger than the upper. But as with people, you know, if you take away the back half of that where you can't see it anymore, what we see is that upper cup that is white, representing the upper jaw, that we know is smaller, looks bigger, but it's a positioning problem with that lower jaw. And this is not too dissimilar to what we see in an underbite, where the lower jaw is trapped back like that. So when the lower jaw is forced to shift or position itself back by a smaller upper jaw, the tongue and all the soft tissues get forced back with it, and they compress all that soft tissue against the cervical spine and constrict that airway. This video here I want to show is a quick little clip, but it kind of puts all those concepts together while at the same time explaining what effect this positioning problem has on the jaw joints and the teeth, and then finishes up illustrating what the airway does.
The normal way to breathe is through your nose. As we grow and develop, certain things such as pollen, cow milk, and other variables can cause an allergic reaction, causing the lymphoid tissues known as tonsils and adenoids to become swollen. As the tonsils and adenoids become swollen, they develop into an obstruction for nasal breathing, and slowly mouth breathing begins to be the primary intake of air into the body. In order to breathe through the mouth, the lower jaw comes down, the tongue comes off the palate and settles on the lower teeth. Nasal breathing is the correct way for air to enter the body, and during nasal breathing, the tongue rests at the palate and the pressure of the cheeks is balanced by the tongue. During mouth breathing, the pressure from the cheeks is unopposed by the tongue. The oral system becomes unbalanced and results in the deformation of the upper jaw, creating a V-shaped arch as opposed to a correct U-shaped arch. This also produces an incorrect swallowing function. Upon swallowing, the tongue rests on the lateral teeth, hindering normal tooth eruption, causing a lateral tongue thrust. A constantly open mouth causes the incisors to over-erupt. The result is a deformation of the lower arch known as the bicuspid drop-off. The result of this deformation of the upper and lower arches is the presence of premature contacts upon closing, which shift the lower jaw distally off of the physiologic trajectory. The narrowing of the upper arch pushes the lower jaw back. This forces the TMJ condyle to shift distally while the TMJ disc shifts forward. Upon opening, the disc can shift onto the condyle to restore the TMJ's correct position. reduction of the disc, and then shift back to an incorrect forward position upon closing. This is what causes a reciprocal click. In addition, the muscles could be in a state of hypertonus or spasm, which can result in tension headaches. An incorrect position of the lower jaw can result in parafunctional activity of the muscles, such as clenching and grinding. Over time, grinding can result in severely worn-down teeth. As a result, the teeth become even shorter, the lower jaw shifts distally even further, and the vertical of the bite decreases. In time, joint degeneration occurs. The joint becomes deformed, and the ligaments of the joint become damaged. As a result, the TMJ disc can get trapped in front of the condyle. While the click may go away, limited mouth opening will occur. A distally shifted jaw and tongue positions result in even further restriction of the airway. In order to open up the airway, the neck moves forward and the head tilts backwards. This stresses the spine and fatigues the neck muscles, which results in neck, back, and shoulder pain.
All right. I really like that video because it kind of just visually ties it together pretty well. So how does this happen? You know, I will delve into the how in much more depth in future webinars, but I do want to share with you a very interesting study that starts us down that road just a little bit. This is a study by Dr. Robert Corricini. Dr. Corricini is an anthropologist, and he studied isolated rural populations, groups of people who have not been exposed to things like processed foods or formula or our modern lifestyles. What he found was that these populations breastfed their children for at least 2 to 3 years. They ate a diet that was comprised of hard, tough foods, dried meats, hard root vegetables, things like that. And what he found was that these populations had very little incidence of crowded or crooked teeth, and they had perfectly formed upper and lower jaws. But where it really gets interesting is that he then follows these populations as Western culture is introduced to them. And very interesting findings in that in the first generation after processed foods and soft diets were introduced, 50% of the population began to experience an increase in malocclusion, this crowded or crooked teeth. After one more generation, that jumped to 70%. And after the third generation, just 3 generations out, that jumps to 85% of the population having, underformed, underdeveloped jaws. What this study and others like it show us is that this structural problem is very much a functional problem. It's not a genetic problem. It's a functional problem. So what can we do? What can be done? Dental arch expansion, also known as craniofacial orthopedic development, can be can be done to non-surgically correct the imbalances that occur over the course of the developmental years. Dr. Guilleminault out of Stanford showed that dental arch expansion improves sleep disordered breathing in patients with upper and lower jaw constriction and can be a valid treatment, further showing improvement, vast improvement of their sleep disordered breathing symptoms. This patient of mine is a great example of what we can accomplish with proper intervention. She was severely underdeveloped in her upper jaw. There was no room that hopefully you can see, no room for the teeth to come in their proper place. Upper front teeth completely covered the lower front teeth. Lower jaws trapped back. Airway was compromised. After treatment with orthopedic appliance, you can look and see how wide and rounded her arches are, teeth straightened up, room for all of them to erupt into place. But more importantly, look at the distance from the chin to the neck. In just 10 months, she achieved a lot of mandibular advancement there. Lower jaw is forward, the joint is healthy, and the airway is wide open. This widening of the dental arches, which, as I mentioned before, is really the scaffolding of the oropharyngeal airway, can have an enormously positive effect on the airway. This patient of mine was a 7-year-old that we treated with, had an extremely trapped lower jaw due to his upper jaw being too small. And as we developed his upper and lower arches, he experienced a very dynamic change in his airway volume. These colored diagrams in the middle are color representations of the volume of that tube that he has to breathe through. This particular child suffered from obstructive sleep apnea and had all the accompanying behavioral problems we often see when children can't breathe. ADHD, tooth grinding, you can see he's worn his teeth flat, bedwetting, and more. And interestingly, all of those symptoms faded away and disappeared as we finished developing his arches. This development can be done at any age. We treat adults who were not able to receive the proper intervention while they were growing up. This patient is a perfect example of what we're trying to accomplish with this treatment. If you look at the before treatment profile, especially where the chin lines up under the nose, she started with a very narrow V-shaped arch, a very narrow airway, but by making room for that in the upper jaw to bring the lower jaw down and forward, it created a bigger airway, better profile, and better functioning jaw joint. This last one that I'm going to show you is kind of that same scenario. If we were to take all the soft tissue away and just look at the bones, this slide shows what's happening to the lower jaw position as we expand or develop the upper jaw. This patient of mine, we treated pediatrically with arch development with an oral orthopedic appliance. On the left is pre-treatment. You can see where the mandible is trapped back by that smaller upper jaw, by that small maxilla, severely constricting his airway. And the image on the right is the same patient after treatment. You can see that the jaw has rotated and shifted forward and is no longer trapped. It has opened the airway tremendously, and just observe the changes in jaw position by that yellow line there. This forward and more functional jaw position allows for better, easier airflow without difficulty that a constricted airway will produce. So we're left seeing all these wide array of symptoms, visible symptoms that show up, all with an underlying cause that can be tied back to a compromised airway. That compromised airway also has a root cause that we treat, specifically these narrow, underdeveloped dental arches. And left untreated, these underdevelopments and imbalances can produce a litany of symptoms that lead to an even bigger list of health problems that Dr. Cole went over pretty thoroughly there. Hopefully in future discussions, we can touch on those signs and symptoms and their related and severe consequences a bit more. But that is what I wanted to share with you guys tonight. And I will turn the time back over to Dr. Winters.
Awesome. Thank you so much, Dr. Hansen. We appreciate all that information. It was really good. Dr. Winters is next. I just want to remind everybody that if you do have questions, put them in the chats or on Facebook and we'll get those answered. Dr. Hansen, if you want to click stop sharing on the screen, I think.
Yep, sorry. There we go.
Yeah, that way we'll get Dr. Winters pulled up.
Well, a big shout out to you, Hannah. I appreciate it again. Said it on the front side, so I'll say it again. Shout out to you to help bring this together and certainly get us more techno useful here. So we thank you for that, and
No problem.
appreciate you on there. You've seen some signs and symptoms, and certainly one of the solutions, along with the other things that's mentioned, and particularly in older adults or mature adults, is the movement of the mandible with an appliance. And this came about some time back in the American Academy of Sleep Practice, a physician-driven organization, recognized this officially in 2015 and gave guidelines and kind of set standards for how best to treat those situations in mild and moderate cases with an oral appliance. And so in that period of time, you begin to see quite a bit of dental related sleep medicine. Prior to that, wasn't as much. There was some. It's been going on around the country a long time. I, in fact, had an oral appliance since 2010. And so, but more recently, the American Dental Association are encouraging dentists to at least screen for sleep apnea or sleep-related breathing problems. There are symptoms that we can see, daytime symptoms and individuals can see, and then intraoral symptoms. And so that's one of the things that I think is occurring along with, periodontal disease and things like that. So our treatment, once it's diagnosed and people understand the consequences, then oral appliances is a treatment. This is kind of what they look like. It's like a mouth guard, and there are over 100 federal FDA-approved appliances. And basically what they do, Dr. Cole mentioned that they do relieve that pressure by moving the mandible forward. Certainly, that's one of the key things in rescuing people to where they breathe better. We do it naturally a lot of times. That's the tongue thrust and the bruxing, and that's mentioned. But that appliance then holds that jaw in a forward position and helps free up that airway, basically to the tongue. So you can see that snoring also happens. Here's a case. That's one of the reasons I sought treatment 10 years ago. My wife, I was snoring, and she elbowed my ribs, and my ribs were getting sore. And that's what happened right here. Just last year, this fellow's wife called us and said he's snoring, and knew I was doing some snore treatment. And so on his phone, he put what's called Snore Lab. And I said, just check and see how you're doing. And sure enough, here's kind of a reading on the left. I made him a rescue appliance, and then 5 nights later, he wore that rescue appliance with the Snore Lab in place, and we see a lot of improvement. He was in the oil field and headed out, and I called his wife then. I said, how'd it go? She said, it's a lot better. I'm going to let him come back in and sleep with me. And so you can do this yourself. I mean, if you got a husband or wife, or you got somebody that, you yourself, if you don't know if you snore, just, we're not a very good, witness to our own snoring. I didn't know I snored, but when my ribs were sore, I knew something was wrong. So anyway, later on, I did a sleep test on him. Well, he still had the rescue appliance in, and these are metrics. The 31 is kind of a standard thing. That's the events where his oxygen, where he was having events in oxygen apneas, and then went to 16 in just about a month there. And so we had him later, made him an appliance when he had time, and we were organized to do that. And certainly are in the process of testing him with a home sleep test post permanent appliance, or appliance that it's not a rescue appliance. So there was significant improvement in that stuff. We want more, and maybe we can reduce some things with his sleep hygiene. He's kind of inflamed. I've been encouraging him to wear an eye mask, for instance. It's one of the things that really helps. We found that you melatonin, if it's darker when you're sleeping, there's other things in there, and we're finding that to be very helpful. And there are even just some homeopathic I guess medicines, or not medicines, but homeopathic things that you can use to help improve your sleep. And so these are some other things, and sleep hygiene helps, and physician makes a difference too, as we mentioned. So what I'm hoping to happen tonight is that, you know, those of you, and I appreciate there's a lot of people on there, and I appreciate those of you that are, in a sense, individuals. There's some providers, healthcare providers on here, but what I hope we were trying to encourage is you'd realize there's some signs and symptoms. And I think it's maybe that the silver lining right now in terms of some things can be with this COVID-19 where you're sheltered, you may realize that some of these signs and symptoms of these conditions that are present aren't necessarily related to something outside, some external environment. It probably are. There's some internal sources for some of these headaches and some of this problem. You might notice it with your children. I mean, they may not be sleeping well, but you can't blame it on the teacher. I mean, they've got something going on, something else maybe. So I think if we'll look around, I think it's one of the things like we do if we're driving along and this service engine light comes on, we know something's going on. That's a warning. And so I hope we've illustrated there's some warnings in the terms of what there's breathing, children, adults, all of us, and that then you have some options to decide what to do. I would offer that you might not want to wait till your engine quits running if you had this light come on. And so I think if you notice some of these signs or symptoms, because in a sense, it's a lot easier to take care of in the first part. There's one of the things that we didn't mention too much, and that's upper airway resistance syndrome, UARS. Affects the young more. It's really, there are a lot of structural things, and there's a lot of challenges, usually those folks under 40. Now, that's, you know, as you get older, there's a lot of, not so much, just as you saw that generational deal. And so the young, we're really structuring a lot of our information to these young folks in terms of that upper airway and how to recognize it and help diagnose it and then treat it. So we'll have another seminar on that. So anyway, we appreciate you attending. There's some doctors from around the country here, some sleep guys we know, and we appreciate you guys dialing in, and we hope we can be helpful in understanding what we do here, and some doctors here locally, some healthcare providers that, and as we kind of, this budding sleep and airway group, as I call it, that's developing here, we hope to have more information and certainly make it available. Again, if you're a patient or you're an individual that hasn't been treated, undiagnosed, untreated, or not successful with your present treatment, then contact somebody, contact us, or contact your dentist, or your physician, and have them, you know, give you some options on how to determine what you have and what best to do. So that's it for this evening, and I'll turn this back over to Hannah.
Awesome. Thank you, Dr. Winters. So everyone has presented, but we did get a couple of questions. So the doctors are going to hang around for a couple more minutes. I'll direct a couple questions their way. If you haven't been able to submit your question yet, if you'll do it on Facebook or on the Zoom chat, we can get those answered for you. I'm going to go ahead and turn the contact information off, but if you aren't able to get it, just let us know in one of those boxes, or definitely call the office and we'll get you that information. Let's see. So one of the first questions that I have, I think will be directed at Dr. Hansen. So let me make sure everybody is unmuted so you can answer these. Okay, Dr. Hansen, when you're treating patients with widening and expansion, do you typically treat both arches?
Typically, both arches get some treatment. The vast majority of the problem tends to be in the upper jaw, so it's going to receive the majority of the movement. But quite often, the lower jaw, especially the dental component, the teeth, will respond to some of the bite forces and other constrictions that are going on. And so we do end up treating the lower jaw as well. It really depends on the problem, but most of the time we're treating both. We just we move a lot more ground on the upper.
Great, thank you so much. Dr. Cole, this question says, My husband has very loud snoring at night that keeps me awake. He is not aware of this and thinks he sleeps great. How do I know if his snoring is just snoring or due to sleep apnea?
That is an absolutely brilliant question, and
Yes.
one that we get all the time. That's a very good question. How do you know when benign snoring ends and sleep apnea begins? Well, without doing a sleep study, it's very difficult to tell. However, there are some warning signs that we look for in the history. We always start looking at diseases by taking a thorough history. So obviously the presence of loud snoring is one alerting thing, but we certainly know that not everybody who snores has apnea. What is very important generally, and what brings the patient in, is after they've been snoring for a number of years, they then start to wake up in the morning and not feel refreshed. We call that non-restorative sleep. And the reason for that is because the snoring has probably moved over into apnea. And with apnea, there are continuous partial awakenings, what we call arousals, in which the brain is kicked out of deep sleep and kicked into a lighter stage of sleep. And this is a response on the part of the brain to not being able to breathe. So in a sense, the brain is saying, wake up and breathe from the apnea. When that happens, people start to complain of poor quality sleep. They start getting daytime symptoms, excessive daytime sleepiness. So now that's not 100%. I have seen patients with severe sleep apnea who don't complain at all of being sleepy. And I have no idea why that is, and nobody else seems to know either. Everybody's perception is different. But generally, when somebody's got very loud snoring and they're starting to complain of fatigue, tiredness, poor quality sleep, that's the time that we generally recommend, let's do a sleep study.
Thank you so much, Dr. Cole. Dr. Winters, I do have one for you. It says, I've heard the cost of an appliance is about the same as having a tooth capped. Is that correct?
Well, yeah, it's very similar. The out-of-pocket expense can be similar to what you might be experiencing in terms of some restorative dentistry or crowning, root canal, things like that. The reason that I think we see dentists today transitioning around the country is because we think the benefits of an oral appliance might even exceed having a tooth capped, in the long range deal. I know, just to kind of tag along on what Dr. Cole just said, I mean, man, I had some off-road incidents during the day, went to sleep, and I'd get honked at into stoplights. I mean, all these symptoms, but I had no clue that I just said I was burning the candle. But this here's what got me. When she was hitting me in the ribs, I decided to take a look, and interesting enough, my home sleep test didn't uncover my sleep apnea problem. It was more that upper airway resistance problem. And so if I showed you my sleep test I took in a lab, it said not significant, no treatment necessary, maybe lose a little weight, some medications and a few things, but didn't really indicate those arousals, even though my blood pressure was going up. So I mentioned that history means a lot. That's the upper airway history. Thank you, Dr. Cole. Real good.
Yeah.
Dr. Hansen, I have two for you I'm going to ask together, if that's okay.
Sure.
One is, about what age do you treat? And then how long does treatment usually last?
Okay, those are great questions. As I had indicated, we kind of treat it at any age. Bone is a living tissue. It's a hard tissue, but it's a living tissue, and we can manipulate it at any age. Pediatrically, we look for kind of a sweet spot between usually around between age 6 to age 10. However, there are certain conditions that we look for that we will treat as early as possible, as soon as we see them. We have to use a little judgment as to whether we think the child can be compliant. But I've treated several 4-year-olds, I think 1 3-year-old, there too. So we do start pretty early in certain conditions that we're looking for. A skeletal crossbite would be one of those that can severely hamper the skeletal growth and cause asymmetries all over the place that will ultimately affect the jaw joint, the airway, and everything else. But for kind of ideal, for most people, ideal pediatric intervention starts about the same time the 2 front teeth start to come in. And for most kids, that's somewhere between 6 and 8, depending on where you fall in your developmental range. And we like to treat as long as we can while before the baby teeth pop out, which is usually happening between 10 and 12. So that's why I say that range is usually 6 to 10 is kind of the sweet spot there.
And then about how long would the treatment last?
Yes, good question. And so that will vary depending on the severity of the problem. The more underdeveloped you are, the longer the treatment lasts. But it's very much like orthodontics for the bone. We're putting slow, steady pressure on the bone and stimulating stem cells to awaken and grow the bone. And so we typically, depending on who you are, can get between 0.5 millimeter to 1 millimeter of growth a month. And so it's a slow process. Most people, I would say, fall between a 8 and 10 month to maybe 8 to 12 month range of orthopedic treatment. And then, the more severe adult cases too, that are older adult bone has to move a little slower. And that can drag on, somewhere up in between 12 and 18 months, depending on who you are. So I should probably mention that we work on the foundation first, and we get the bone the right shape and size that it needs to be. And then after that, most of the time, not always, but most of the time, we have to follow that with some orthodontics to line the teeth up in that and solidify that forward jaw position with a good bite.
Awesome. Thank you, Dr. Hansen. Let's see. Dr. Winters, do you treat things beyond snoring and sleep problems at your Edmond office?
No, I missed that one. Tell me again.
Do you treat anything besides snoring and sleep problems at your office in Edmond?
No, I'm just transitioning, totally specializing in treating the snoring and sleeping, solutions with problems with oral appliances here. So I've had, it's a good question, because I have some of my pals or people that were previous in my practice when I practiced out in Bokeene, wanting to come down here, wanting to, come to my office, and I got to tell them, doggone it, I'm thinking, trying to help save lives instead of save teeth. I guess look at it from that standpoint.
Thank you. Dr. Cole, I do have another question for you. It says, my spouse was prescribed a CPAP for his sleep apnea. He wore the CPAP for a few weeks, but now doesn't think he needs it anymore. What can I do about that?
Record his snoring. Now that's a common problem. People have trouble with CPAP for many different reasons, but probably the 2 most common reasons that I see where they're not able to wear CPAP is, number 1, nasal obstruction. If somebody has nasal obstruction for whatever reason, allergies, deviated septum, broken nose, turbinates, it is very, very uncomfortable to tolerate having air blown in under pressure into a partially or completely obstructed nose. So when I see somebody who is intolerant of CPAP, I immediately go to the nose. I take a look at it. I'm very aggressive with treating allergies topically with nasal steroids, antihistamines. On more than one occasion, I have referred patients to the ear, nose, and throat surgeon, not because I expect that they're going to cure the sleep apnea, but various surgical techniques can make the patient more compliant with their CPAP. The other thing that I see, which makes it very difficult for patients to wear their CPAP, is they were never set up with the proper interface in the first place. And, you know, setting up CPAP is not like prescribing a wheelchair or a commode. You can't drop it off at somebody's front door and expect them to understand what to do. It takes a lot of coaxing, a lot of effort. You need a very good sleep tech or a good DME equipment person to really work hard with the patient to find the right interface. I always tell the story. I had one patient who went through 4 separate masks, was ready to give up, and on the 5th different mask, a very bright sleep person prescribed a hybrid mask, an oral and a nasal mask. They loved it, and they have been compliant ever since. So when somebody gives you the story that, oh, they can't tolerate CPAP, I can't stand the mask, there are reasons for it. And if you find them early, like within the first 2 to 4 weeks, you can save somebody and make them a compliant CPAP user. There's always a way we can help people.
Thank you, Dr. Cole. I have another one for Dr. Hansen. It says, do your patients use myofunctional therapy in conjunction with their appliance? I guess this could go to Dr. Hansen or also maybe Dr. Winters as well. Dr. Hansen, if you want to go first.
Yeah, for my part, absolutely. You know, as I was mentioning, that tongue is one of the most important pieces of the puzzle, and to get a good, stable outcome, we have to have that tongue functioning correctly. And so, yeah, myofunctional therapy, which is basically like physical therapy for the tongue and oral muscles, is very important. And you know, we try and look for and recognize those dysfunctions when we see them. And in some cases, we can recommend some very simple exercises to be done. A lot of times we will manipulate our appliance to aid in that, so that there's, for example, a bead that sits in the appliance that you go back and play with your tongue to train that tongue to go back and up into the palate. In some cases, though, that the dysfunction is so set in that we need to call in some backup, and we'll get a myofunctional therapist in and start working with those patients while we're at the same time working on the foundation and fixing the structure. But we also want to go after that muscle problem, because if we don't get good muscle function, it can undo what we do with our appliances.
Well, I can echo that. I mean, that's one of the challenges we see with oral appliances is just their tongue. The comfort of the oral appliance is and the success of it. You know, get it in a therapeutic position where you help that airway collapse. If you improve that, which you can do with the pharyngometer, then you want to try and encourage them to then have nasal breathing and not have that tongue wanting to come anteriorly. So the type of the appliance you make and you know, some, like you say, myofunctional encouragement and maybe some retraining, because if you realize the benefit of nasal breathing and not letting that tongue go back, then it'll sure be helpful, and you'll be more successful in keeping that airway open in those patients that's a challenge for. So we're looking to have some videos for patient education on that, and also some breathing techniques. There's some breathing techniques that tend to help reduce inflammation and things of that nature. So I think that's what we see in the advance. I mean, I just kind of go on. I think we're on that upswing, that curve of where people are realizing there's a lot of little factors enter into sleep, where you have nutrition, you have exercise, there's lots of things being done on that. And I think sleep and airway, functioning are going to be what is now, the thing that we'll be probably focusing on medically and health-wise, and we'll see a lot of improvement because of several factors. So I think it's a nice time to be thinking about how is your quality of sleep. And is it, like you mentioned, are you becoming or recovering from your sleep, and you're restoring your sleep, restoring your health, and that's what sleep's intended. What's intended for. And so structurally or functionally, there's all things that's intertwined. That's why I love a sleep. That's why I love a collaborative group where you're looking at various reasons for that.
Sure.
I'll just mention that's new to the collaborative group is new to Oklahoma City in a sense. I'm not aware of any like that, but we do know there's some around the country that there are collaborative groups of different multidisciplinary providers that are working together to, get the outcome that I think people can be happy with, that they're successful with and they're comfortable with, and they realize the benefit. And so it's for all ages and things of that nature.
Awesome. Well, thank you so much, Dr. Winters, Dr. Hansen, and Dr. Cole. Thanks for taking time this evening, presenting what you do in your office with your treatment and how you guys work together. Also, thank you to everybody that tuned in tonight. We're really happy to have everyone here. Thank you for your questions. These videos will be saved to Facebook, also YouTube. If you have friends, send it their way. This is information that's important now. All these doctors are definitely sensitive to the situation that we have going on right now with COVID-19, but they will be here to treat your sleep problems and are available now for questions. We put their office information, give them a call. Even if you're not ready to seek treatment now, they're happy to answer your questions. So thanks so much everyone for tuning in.